microcircuit of the neurons inside the cerebellum. We have seen that Purkinje cells inhibit the deep nuclear cells. Both of them are activated by muscle fibers and climbing fibers, right? And muscle fibers induce simple spikes. Climbing fibers induce complex spikes in the Purkinje neurons, right? So now, let's see the connection between them again. Purkinje cells and deep nuclear cells fire continuously.
Sir, you talked about the oscillatory movement in the complex movement spikes, right?
Yeah, simple spike, complex spike.
Is it the same as we talked earlier, like the oscillatory and reverberatory circuits?
No, that was oscillatory circuit. So that was some neurons. But here, we have spikes,
Just
action potential. Yeah. So they are completely different. Okay.
Sir, if we will remember for the complex action potentials, the influx of calcium, is that applicable? Like when we remember complex action potentials, we will remember here the influx of the calcium.
Yeah, here we have influx of calcium and then influx of sodium. So we have both of them. First, calcium enters the cell, we will have upward movement in the resting membrane potential.
And when the sodium
above this, you will have opening of sodium channels, the potassium channels, and you will have the standard action potential. Okay?
So oscillation is below the threshold?
No, actually it's above the threshold, but the oscillation is made by calcium channels. Okay, so they remain open. So this way they keep the potential above the threshold. So as long as it's above, you will have also action.
Oscillation and impulse is same in case of complex spike.
Oscillation, yeah. So the whole thing is called complex.
Sir, can you show that slides?
Yeah. Here. So let me check there.
No, not this slide. The diagram.
So let's clear up this. Okay. So these are simple spikes. These are called complex spikes. So the entire event is called complex. Okay. So the diagram here you mean?
Yes, sir.
Okay. Purkinje cell. So simple spike and complex spikes happen here inside the Purkinje cell. Both muscle fibers and climbing fibers release glutamate. So both here and here they release glutamate. Glutamate activates this one. But this one is inhibitory. It inhibits this. Yeah, okay? So let's come back here. Purkinje cells fire at about 50 to 100 action potential per second. Deep nuclear cells fire at much higher rate. So they release GABA, glutamate, and sometimes they release also GABA. Okay, so I told you to ignore this and stick to this. Okay? The output activity of these cells can be modulated outward or downward. So in the resting state, both the Purkinje cells and deep nuclear cells are active. They always generate action potentials. Okay? But the action potentials can be increased or decreased depending on the inputs to the cerebellum. Right? Deep nuclear cells are excited by climbing fibers and muscle fibers because they release glutamate. Are inhibited by Purkinje cells, they release GABA. There is a balance between excitation and inhibition, which is slightly in favor of excitation. So that's why you always have activation in the deep nuclear cells. So, in the resting state, deep nuclear cells keep activating the output targets. Remember the outputs? From the fastigial nucleus to reticular. From the interposed nucleus to, for example, reticular formation, rubrospinal tract, also, right? Reticulospinal tract. So, all of these centers are activated in the resting state by the cerebellum. So cerebellum has an activating action on the motor centers. Right? Okay? So, now imagine that you want to have a movement like this. Okay? So, for this movement, agonist should be activated. Okay, so agonist is flexor. So let's go with this one. Okay, so this one is the extensor of the arm. Okay? So you want to have this. So this muscle should be activated. Any movement has a start and an end. Right? So let's see what does the cerebellum at the beginning of the movement and at the end of the movement. So in execution of a rapid motor movement, initiating signals from the motor cortex and brainstem increases deep nuclear cell excitation. This way motor output pathways increase. A few milliseconds later, feedback inhibitory signals from the Purkinje cells arrive. It helps stop muscle movement. And that's movement oscillation. Okay, so let's see this one. So you wanted to have this. The muscle which is involved is triceps, right? So what motor area causes this movement? This movement? Cortex, right? So we have planning in the premotor, supplementary motor, then we have performance or the action by the primary motor. Primary motor sends information through corticospinal tract, right, to cervical areas in the spinal cord. Anterior motor neurons from here go to the triceps, activate the triceps, we have contraction. So everything is started from the cortex. So cortex sends information through the corticospinal tract to the muscle. You will have contraction, right? At the same time, the cortex also sends information to the cerebellum. Which part of the cerebellum? Intermediate zone. Because limbs are actually controlled by the intermediate zone, right? Intermediate zone sends information to the interposed nuclei. Interposed nuclei to rubrospinal, corticospinal. They help movement in the arm, okay? How? I told you that we have this circuit. So from the cortex, muscle fibers come to the cerebellum. Right? Intermediate zone. So first they go to the interposed nucleus. They activate the interposed nucleus send the information back to the cortex. So cortex starts the movement. The cortex itself is activated further by the cerebellum. So it sends more information to the skeletal muscle. So the skeletal muscle can contract heavily, strongly. Okay? Then, muscle fibers from the cortex bring the information here, right? I told you about this. But another version goes upward, activate granule cells, activate Purkinje cell. Purkinje cell inhibits the deep cerebellar nucleus. So this cell then is inhibited. This inhibition stops the movement. So, at the beginning of the movement, cerebellum causes further excitement. At the end, it puts a brake on the movement. So, it determines the start and the end of the movement. How? By this circuit. You have a short loop, a long loop, right? Short loop activates the agonist, long loop inhibits the agonist. Got it?
So Purkinje cell is always inhibited for the deep cellular neurons.
Purkinje cell? Yes. It's always inhibited. So, now let's see the writing here, I told you. At the onset of a movement, rapid turn-on signals happens for agonist muscle by the cerebellum. See? I told you. First, cortex sends information toward the muscle, right? Let's see this. Turn-on signals, signals that start the movement. From the cerebral cortex, go to the brainstem and cord pathways, corticospinal, root response, right? They go to the agonist muscle. So the cortex is gonna have movement in the triceps, right? Then parallel signals from the cortex go to the pons, pontine muscle fibers. They go to the deep nuclear cell. Deep nuclear cell is excited and send excitatory signal to cortex. Corticospinal system is activated, right? So the turn-on signal from the cortex becomes more powerful, right? So the cerebellum supports the cortex to have contraction in the muscle. This is at the onset of the movement. Then, when the movement is going to be ended, on approaching the termination of the movement, the cerebellum should stop the movement, right? Should stop the movement. So, turn off signal is sent to the agonist. How? Muscle fibers, second branch. Go to the granular cell, activate parallel cells, Purkinje cells are activated. They inhibit the deep nuclear cell. Deep nuclear cell removes its support from the cortex. So at the beginning, it supports the cortex. At the end, it removes the support. Right? So this way, it can make a movement very powerful at the beginning, then it breaks the movement at the end. Got it?
Yes, sir.
So this is,
But the initiation of movement is from the motor cortex, right?
yeah, initiation happens from the motor cortex. I told you, motor cortex, activate the ventral corridor, contraction in the muscle. Right? So at the same time, motor cortex activate the cerebellum, cerebellum activates the cortex, so we will have more powerful action. At the end of the movement, cerebellum inhibits the cortex or remove the support. Right? Then the cortex stops the movement.
Sir, can you explain the second one again?
The second one,
Yes.
you asked me?
Yes.
Okay, the movement was already started. Right? The cortex sends information to the skeletal muscle and the cerebellum. Cerebellum supports the cortex. Now, at the end of the movement, some fibers go to the granular cells. So the first one happens by this pathway. Right? Support happens by this pathway. But we have another loop here. So, muscle fibers activate granular cells activate Purkinje cell inhibits the deep nuclear cell. So, deep nuclear cell is inhibited. I told you that, at rest.
Yes.
And at the beginning of the movement, deep nuclear cells activate the cortex. Now they are inhibited. So they doesn't activate the cortex anymore. Right? The cortex actually loses its support from the cerebellum. So the movement is ended. Okay? So it's like having a break on the movement.
Sir, it means that if cerebellum is not working, cerebral cortex is not working,
Cerebellum
cerebellum
cortex,
is
yeah.
not working.
So the cerebellum cannot do any function alone. It needs the cerebrum, and also the reticulus, the reticular formation. So all of them should be present in order to cerebellum coordinate. Right? So you have seen that we have two loops here, an excitatory loop and an inhibitory loop. The excitatory loop actually supports the beginning of the movement, the start of the movement. The inhibitory loop actually inhibits the movement or stops the movement. Got it?
Yes.
Yes? Good. So, this means when you have a movement like this, okay, it may take, for example, 0.3 seconds. Right? 0.3 seconds. Only for example. So, at the beginning, the cerebellum helps the cerebral cortex to start the movement. Then the break should happen exactly at this time. Right? So what does it mean? It means that the second loop should be run during this time. If it's later, or if it happens sooner, it means the movement is not precise. Right? So, consider another situation. You want to do this movement faster. Okay? So you need to do this instead of 0.3 seconds in 0.12 seconds or 1 second. So what does it mean? It means this loop should activate or should be run faster. Okay, so this is the learning of the movement. So for example, you are taking boxing lessons, okay? So first, when you are a beginner, you hit the person, for example, in 0.3 seconds. Slow. Now you learn this after a while, okay? And you hit him faster. Okay? So this movement happens faster. So the cerebellum learns this. How? It should actually activate the movement faster, break the movement faster. Okay? So how this may happen? By facilitating these synapses. You know facilitation. So if you increase the level of activity in a synapse, then when the original signals come to the circuit, it can run through this circuit faster. Okay? So how this happens? You see? I told you that there are climbing fibers, muscle fibers. We have seen that muscle fibers are involved in the start of the movement, end of the movement. What about the climbing fibers that are coming from the inferiority? They can modulate the activity in the synapses.
Sir,
They generate complex spike, right? Complex spike facilitates the synapse. So the same synapse can pass the signals faster than the normal situation.
Can you repeat, sir?
Yeah. So we have seen here in this circuit that muscle fibers from the cortex can give extra support to the movement, right? For the beginning of the movement. Then the second branch of the muscle fibers activate Purkinje cell. Purkinje cell inhibit this one, so it can pose some brake on the movement. So it gives them in the end of the movement. So muscle fiber is involved in the start and stop of the movement, right? Or the end of the movement. But what about the climbing fiber? Climbing fibers can change the sensitivity of these synapses. All of the synapses that we have in the spinal cord, especially this one, Purkinje cells. So you can see that climbing fibers climb these neurons. They actually turn around the dendrites. They release glutamate here, right? They can activate the Purkinje cells. So they can change the sensitivity of these synapses. So from now, they will answer or they will respond to the parallel fibers more easier. Okay? So muscle fibers can activate these synapses easier than normal. Okay? So this way, this loop can inhibit the deep cerebellar nuclear cell faster than normal. Okay? So the movement starts faster and faster. So this is the learning of the movement. When you can do a movement faster than.
So muscle fiber is always coming from pontine nuclei, yes, from other part of brain also.
So this one?
Yes, sir. It's always come from pontine nuclei.
So I told you that all inputs to the cortex, to the cerebellum are muscle fibers except
the inferior. So this muscle fibers always generate from pontine nuclei.
No. Some of them are from pontine nuclei, others from the spinal cord, others from the cerebral nuclei.
Function is same.
Yeah, the same function. So I gave you an example of a movement in the arm. You can have another example of movement, for example, in the back. Okay. So for example, you want to do this. Okay, and you learn this. Okay. So muscle fibers from the reticular formation, from the vestibular nuclei are involved in this movement, so they can start the movement powerfully. They can break the movement faster. Okay, so they help the reticular formation and the vestibular nuclei to do these functions better, right? And then they can also learn to do these movements faster than normal.
Sorry, I came late, but it's motor simulation
For what? For which one?
from the beginning. Yeah, from in there.
Yeah, it is.
It's somatic or automatic?
So they are somatic usually, because motor systems that I talked about them are somatic.
So
Okay.
it's not working on the heart like
Yeah. So actually, the autonomic nervous system is totally different. They are not under the control of the cerebellum.
Sir, motor function is controlled by cortex,
Yes.
and the activation of inhibitory neuron in this cerebellum means that it is not participating in the planning. It doesn't mean that it's the contraction will stop.
So, the example that I gave you is about the movement which is supported by the intermediate zone. Okay? The same also happening in the lateral zone. So the same circuit is functioning in the lateral zone, so it can help the cerebrum for planning.
Yes, sir. If the inhibitory neuron is working, then it will not participate in planning.
Sorry again?
The function of cerebellum is planning the movement.
Planning of the movement,
Yes.
not the whole circuit of the cerebellum. I told you it has several divisions. The lateral zone is important for planning.
Yes.
It means that the cerebellum will directly act as the motor. It will
No,
Increase
it's
the
not,
motor.
it's not the origin of the planning. The origin of planning is in the premotor system, supplementary motor system. In order to plan, they send information to the cerebellum. Cerebellum gives them back the signal, and this way the planning can happen faster.
It means cerebellum will perform the motor function too. Beside planning, it will perform the motor function.
Yeah, but by this loop, actually. The origin is the center.
Yes, sir. After
So if you remove the cerebellum, planning is also lost.
after coming to the cerebellum, it will go back to the cortex,
Yes?
and then the motor.
Yes, then to the motor areas in the cerebellum.
Yes, sir. If the inhibitory neuron in cerebellum means that it is not involved in the planning.
Why?
Sir, because there is no direct motor neuron there.
Yeah, I told you, there is no direct connection between the cerebellum and ventral cortex.
This line.
Okay, there is no direct relation between these two. The center wants to plan for a movement here. Before the planning, it sends information to the cerebellum, get it back. This way, the cerebellum is involved in the planning.
Sir, I am asking that what is the function of this inhibitory neuron?
Inhibitory neuron, you
Yes,
mean? Okay, I got you. Okay, I don't know. Because nobody knows that. Okay? You know, are only some theories. All of these that I mentioned are theories about the function of the cerebellum. You cannot find any clear picture of the function of the cerebellum in any textbook, in any article. Nobody knows it. Areas in the brain that we generally know their functions, but we don't know specifically the type of the function they do in the general action of the brain. Okay? So the cerebellum has a lot of things that we don't know about them. And also the basal ganglia, it's actually more complex. Okay? So I got your point now. So he says that if the theory applies for movement in the limb, how the same can apply for the planning of the movement. In the planning, we don't have a start and end of the movement. Okay, like this. Okay, I know this, but actually it's something that hasn't discovered yet. Okay, so you can read a lot of textbooks about the cerebellum, but none of them talk about this.
All this here.
Okay, actually it's not discovered yet. Okay, so there are a lot of works that are going on now on the cerebellum. Now, okay, we talked about the agonist muscle, right? Yeah, agonist muscle. But for any movement, the antagonist muscle should be also relaxed. So we have seen that the cerebellum aids at the beginning and at the end of the movement in the agonist muscle. So antagonist muscle should be relaxed. So we know that we have reciprocal circuit in the spinal cord. Maybe the reciprocal circuit is mainly involved in the antagonist function. Or we also know that we have inhibitory cells like stellate cells and Golgi cells in the cerebellum. They may also be involved in the relaxation of the antagonist. So, I also talked about the learning. I told you that the degree and the timing of the support is adaptable by the action of the climbing fibers mainly. Right? I mentioned this. Here you can see an example of recording from the Purkinje cells, deep nuclear cells during the movement. So the movement is this one, flexion, extension of the wrist. Okay? So a monkey is doing this repeatedly. So here you can see the flexion, and here you can see the extension. So flexion, extension, right? So before the flexion and extension, you can see the firing rate in the Purkinje cell and in deep nuclear cell. So I told you, in the resting state, they are always active. So the deep nuclear cells send action potential to the cortex, with nucleus, reticular formation, vestibular nucleus, so they keep them active. Right? Now, when the animal do this and this repeatedly, the activity, the firing activity changes. You can see that during the flexion, the neuron is inhibited. During the extension, neuron is highly active. The same also happens in deep nuclear cells. So, during the extension, the neuron is very active. When it flexes, neuron is inactive. So this image only shows that for any movement, deep nuclear cells and Purkinje cells change their firing rate in order to help the cerebral cortex do the movements better. Okay? So let's see some of the clinical problems of the cerebellum. I told you before that if you remove the cerebellum, there will be no paralysis, no sensory loss, no problem with understanding the movement. The only thing that happens is coordination. Coordination is lost, especially for rapid movements. Right? Because when you have a slow movement, sensory feedback to the brain can cause some compensation, some correction. But when the movement is very fast, the sensory information doesn't have time to correct the movement. Okay? So here the importance of the cerebellum is shown for rapid movements, right? So the cerebellum prevents overshoot and damp movement oscillation. What does it mean? For example, you want to do this movement. Okay, the movement has a start and an end. The end should be exactly here. If it ends here, the movement is wrong. If it ends here, again the movement is wrong. The movement should be exactly end here. Right? So the cerebellum functions to perform the action precisely. If the cerebellum is lost, the movement may pass, or so we will have overshoot or undershoot. Okay? So we call this pass pointing. So the target is passive. Okay? So when the cerebellum is lost, the movement is not correct. So the movement passes the target. We will have the overshoot. The brain sees that, oh, the movement was performed wrongly. So the brain again tries to make it correct. So the second movement is started. Right? The second movement, it should be this way. Right? But again, the second movement is not precise. So it passes the target again. Right? So the brain generates the third movement. This way. Right? So again, this one is not right. So it passes again. So we will have oscillation of the movement around the target until it ends here. So after several incorrect movements, then the brain can do this correctly. Okay? So if the cerebellum is lost, we will have actually tremor like this, oscillation of the movement, pass pointing. All of them are called ataxia or dysmetria. Okay?
I saw Joe doing like this, maybe it's because of this.
Yes. Cerebellum. So, when the cerebellum is lost, the movement is not correct. So, what happens for fast movements? The movements will be slow, weak, and the movement stops slowly. So it goes beyond the mark, beyond the target. Automatism of ballistic movement is lost, right? So the condition is called ataxia. Ataxia is an uncoordinated movement due to the errors in rate, the speed, the range, okay, the force, and the direction. So if the direction, force, range, rate are uncoordinated, we call this condition ataxia. Ataxia can happen in limbs or in truncal muscles. So we will have limb ataxia, which happens in hand, arm, legs, or eyes. Or we may have truncal ataxia, which is manifested by a wide-based gait. Okay, so the person, instead of going this, okay, walking this way, to try to put the legs wide. Okay, because there is problem with gait, problem with balance, equilibrium. Okay, in order to compensate for that, the patient tries to put the legs wider. Okay, so we have a wide-based gait, wide-based drunken sailor gait. Okay, so.
So can we say that in sports sports athletes, cerebellum is more developed?
Cerebellum is what?
More developed in the sports, yes.
In a sport, yeah. So when you learn something, and any motor movement, okay, actually your cerebellum gets better and better. Okay, so they have better functions. So, for example, in a person which plays piano, the cerebellum is very advanced. It's very actually skilled. Actually, okay. So when you learn anything by hand, okay, the cerebellum makes important contributions to this learning. Okay, so
Doctor, what things that damage cerebellum?
what things may have damage to the cerebellum? So there may be direct damage like trauma, or some diseases, like, for example, using some drugs like phenytoin. So phenytoin is a drug which is used for seizure and epilepsy. Usually it causes damage to the cerebellar cells. Okay, maybe alcohol causes this. Okay, so there are a lot of conditions, neurodegenerative diseases like MS, multiple sclerosis. Okay, so all of them may cause damage to the cerebellum. There are a lot of things. Okay, so you will see them in clinic, in the pathophysiology. So let's go on. when there is a lesion in the right cerebellar hemisphere, the movements on the right side will be delayed. So cerebellum function to do the movement fast. When there is loss, movements will be slow. In this situation, you can see an example. You ask a person to clench their fingers, okay? So you put the ball into the hand and ask the patient to press them actually at the same time. So the person should do this, okay? So when there is damage on the right side of the cerebellum, you can see that there is a delay in the movement in the right hand. But the normal hand actually doesn't show any delay. So when you ask the person to start the movement, after some milliseconds, the movement is stopped. But you ask the person to do the movement, but in the right hand, the movement happens slower and there is a delay also. Okay? Another condition is symmetry. So you will have finger to nose test. You ask the person to put the tip of the finger to the nose. Okay? So in normal situation, there is a direct pathway from here to here. But a patient with damage to the cerebellum may have problem putting the hand to the nose, especially when the finger gets closer to the nose. Okay, so we have this, actually this is called dysmetrium, and also the composition of movement. So movement is decomposed instead of being direct. Right?
Sir, what is that go? It was written go.
Yeah.
Yeah.
Yeah, we ask the person to start.
It's a very conceptual.
A rebound phenomenon. You ask the patient to stretch the arm, okay, hit it. It should come back to the same position. Okay, if there is damage, it goes down and then there is overshoot. Okay, there is overshoot. So this is called rebound phenomenon. Or another condition is histiocokinesia. Histiocokinesia. Okay, so you ask the person to do this movement repeatedly. Okay, so this should occur smoothly. So this is normal condition. But a person which has actually cerebellar damage do this actually ununiformly, or it's not like this, okay? There are abnormalities in the movement. So the progression is lost. Progression is going from one movement to the next, right? Progression is lost. Dysarthria, problem talking, problem speaking. Okay, the intensity, the duration of the sound lost. The patient may have slurred and scanning speech. Nystagmus. Okay, nystagmus means when you ask the person to look at something located peripherally, for example here. Okay, so the eye try to have a gaze on this object, but the movement is not correct. It passes the target. Okay, so it goes this way. So the second movement, which is a corrective movement, again passes the target. So the eye movement actually shows some oscillation around the target. Okay, so there will be some repetitive movements in the eye. So this is called nystagmus. Nystagmus hypotonia, I told you again. In the resting state, the deep nuclear cell keeps activating the targets. Cerebellum, red nucleus, reticular formation, right? So the targets are always activated by the cerebellum. When there is loss of the damage, the cerebellum or any damage, then this tonic movement or this tonic activation is removed, right? So the targets are not activated, the result will be hypotonia. So the tone of the muscle will be less than the normal. So hypotonia happens in these patients usually. So, you know that we have different areas in the cerebellum. So when these phenomena, these problems happen in some special areas of the body, you can infer or interpret the location of the damage in the cerebellum, right? For example, when there is disequilibrium or nystagmus, I told you that eye movement and posture or balance are helped by vermis, flocculonodular lobe, right? So these problems may indicate a damage in the vestibulocerebellum. But when there is problem in the control of limbs and axial muscles, there may be some damage in the vermis, fastigial nucleus, right? Damage to the cerebellum may cause problem with smooth progression of the movement and the composition of the movement. So when the finger to nose test is abnormal, then the problem is in the cerebellum. When there is ataxia, loss of the equilibrium and the posture, there is problem in the flocculonodular lobe. Nystagmus shows a problem in the flocculonodular, right? Rebound phenomenon and other things, and scanning speech, problem with posture, they may indicate the damage in the spinal cerebellum. Okay. This was about the cerebellum. Now let's start the basal ganglia. We are actually out of time. And the basal ganglia also make some accessory centers for the control of the movement. So they are not directly involved in the movement. They help the cerebral cortex to perform the action, to plan and perform the action. So, another accessory motor system is the basal ganglia. They receive signals from the cortex, send the signals back to the cortex. Right? Neurons in the basal ganglia fire before the action. So when you want to move your hand, basal ganglia are activated before the movement, not during the movement. Right? So we can say that they are important for planning the movement, for preparation of the movement. Right? Planning and programming. So you know the basal ganglia, you have seen them in the neuroanatomy. They have caudate, putamen, globus pallidus internal, globus pallidus external, subthalamic nucleus, substantia nigra, pars compacta, pars reticulata. Right?
Accumbens.
And?
Accumbens.
Accumbens. Yeah, accumbens is part of the caudate nucleus. Right? So, in this image you can see that these nuclei are interconnected together. So you can see that, for example, the caudate nucleus releases GABA onto the putamen, and in the globus pallidus, both external and internal. So they release GABA. They also release GABA in the substantia nigra. Right? So internal and external globus pallidus release GABA also. Substantia nigra release dopamine. Where? Putamen, caudate. Right? So you know this. And you have also norepinephrine, serotonin, enkephalin from the brainstem, which is released in the basal ganglia. So this is from the guidance group. Okay? But this one shows the connection better. First, let's consider this one. Okay? So from the cerebral cortex, neurons go to the putamen or the caudate. The caudate is not shown here for simplicity. Okay? So fibers from the cortex release glutamate in the putamen and caudate. So, some of the neurons activate putamen neurons, inactivate globus pallidus internal. So, neurons from the putamen may bypass the globus pallidus external. I mean, they have to do this, and there is no synapse here. They go directly to the globus pallidus internal. Globus pallidus internal is the output of the basal ganglia. Okay, so the input is putamen and also subthalamic nucleus here. So they receive inputs directly, but the output is globus pallidus internal, right? Globus pallidus internal inhibits the thalamus. Thalamus activates the cortex. So we call this pathway direct pathway. Did you have this in your anatomy? No?
Yes.
Yes or no?
No.
No, we did not see.
Okay. So again, we have direct pathway, indirect pathway. I talked about the direct one. The direct starts from the cortex, releases glutamate in the putamen, activate putamen neurons. Neurons here are GABAergic. They release GABA in the globus pallidus internal. Globus pallidus internal neurons are also GABAergic. They release GABA in thalamus. Thalamocortical neurons are excited. So now let's see the general action. We have an excitatory neuron here, which excites this. This one is inhibitory, so inhibit this.
Sir?
Sorry. This inhibitory neuron is inhibited by this one. So it cannot inhibit the thalamus. Thalamus activates the cortex. So the whole pathway is excitatory. So, actually you should memorize this, okay? It's very important. So, from the cortex, you have glutamatergic neurons, right? Activates what? Putamen. This one is GABAergic. Release GABA. Where? Globus pallidus internal.
So it's not important which we know GABA A or B.
So we have GABA A and GABA B receptors here. Okay? GABA activates GABA A, GABA B. GABA B receptor and GABA A receptors inhibit these. This one is also GABAergic. Where it is released? Thalamus. Which nucleus? Ventral anterior, ventral lateral. Thalamus is excitatory. Excites the cortex. Okay, glutamatergic. So, you have activation, inhibition, activation. Okay, so let's show activation by plus, by positive, inhibition by minus. Activation, inhibition, another inhibition, activation. Right? So you know that two negative signs of positive. So the whole circuit is positive. So, cerebral cortex send neurons to basal ganglia, right? Basal ganglia has two inhibitory neurons. The result is activation of the thalamus. Thalamus activates the cortex. So the cortex activates itself through this pathway, right? So this pathway is excitatory. Now let's see the indirect pathway. Cortical neurons activate putamen. Putamen inhibits globus pallidus external. External inhibits internal. Internal inhibits thalamus. So you have excitation, inhibition. Three inhibition. The overall will be inhibition. So thalamic neurons are inhibited. They cannot activate the cortex. The result is decreased activation of the cortex. So the indirect pathway is generally inhibited. So I told you that Basal ganglia are accessory centers. They generate a loop between the cortex and thalamus, okay? So it receives from the cortex, sent back to the cortex. It's a loop. It can have excitation of the cortex by the direct pathway. It can have inhibition of the cortex by
Indirect.
So, actually, again, this is a theory. We don't know if it's really true or not. Okay? We have wanted movements, unwanted movements. Right? For any movement. For example, when you want this movement, this is the wanting movement. All other movements are unwanted. Right? So, direct pathways activate the cortex to perform wanted movements. Indirect pathways inhibit the cortex to suppress unwanted.
Unwanted movements.
So this is the general view. Okay? So, another pathway for indirect pathway here. So, cortex activate putamen. Putamen inhibits globus pallidus external. This one inhibits substantia nigra. Okay? Substantia nigra doesn't activate globus pallidus internal. Globus pallidus internal cannot inhibit thalamus. Okay? So this is another pathway. So we have two sub-pathways in the indirect pathway. But again, the general feature is inhibition.
Inhibition of
So direct pathway is excitatory, indirect pathway is inhibition. So now let's see what are the physiological importance of these pathways. I told you that pathways from the cortex can go to the putamen or cortex. Right? Putamen and cortex has different functions. The putamen circuit is involved in learned patterns of movements. Anything that you have learned before, any movement that you have learned before, is supported by the basal ganglia. For example, you have learned to write when you were 7, right? You may learn to swim. For example, you know to ride a bicycle. Some of you may know to play piano or play guitar. Okay, so these are different types of movements that you know that. Or all of you know to scissor a piece of paper. So this is a movement, special movement actually, right? So these learned movements are supported by the basal ganglia. Which circuit? Putamen. So from the cortex, signals go to the putamen. They go to direct and indirect pathways. They come back to the cerebellum, to the cerebrum. In the cortex, they can support the movement. Okay, so learned movements are supported by putamen circuit. If there is loss in this circuit, learned movements are lost. For example, writing the letters of the alphabet are actually abnormal. Okay, so they are not performed in a normal way. Okay, so we have, so let's see first this one, and then I will come back to the others. So the caudate circuit is involved in cognitive control of motor activity. So two key expressions here are learned motor pathways or learned motor patterns and cognitive motor activity. Cognitive means all motor movements are performed by thinking.
consciousness.
Yeah, they happen at the conscious level. For example, you want to reach here, but you're not high enough to reach here. So you think about that. You bring a chair and go up, and then you can reach there. Okay? So your thought, you think about that. First, you do this movement, then this movement, you go up, then you can reach. So you have done a course of actions in order to reach a target. Okay, so you think about that. By sensory information, by memory. Okay, so this is the cognitive control of movement. Or you see something frightening here, you go out of this, okay, this room. So you escape actually. So this is the cognitive control of the movement. So for cognitive control of movement, anything is different. Information comes to the caudate nucleus, they go to the direct and indirect pathway, then they come back to the cortex. But they go to the prefrontal cortex here. Area of the cortex important for thinking and for planning, decision making. Right? So compare this one with this. Everything starts in the motor cortex, go to the basal ganglia, come back to the motor cortex again. This is for learned movements. But here, it starts from the cortex, motor cortex, sensory cortex, go to the basal ganglia, come back to the cortex, but the prefrontal cortex for thinking. Right? So, some abnormalities in the putamen circuit. Lesion in the globus pallidus causes spontaneous and continuous writhing movements, like twisting. Okay? So we call this athetosis. Athetosis, okay? It may happen in hand, arm, neck, and face. Lesion in the subthalamic nucleus causes flaring movements, like swinging movements. Okay? Cannibalismus. Lesions in the putamen called flicking movements in the hand, face, and other parts. We call this chorea. Lesion in the subthalamic nucleus causes Parkinson's disease. Okay? So I have some videos I'll show you at the end of this class about these. Okay? So, let's see this one, Parkinson's disease happens when you have any damage in this substantia nigra portion. Okay. First of all, I should mention this. Dopamine is released from the substantia nigra onto the putamen and caudate. Dopamine activates direct pathway, inhibits indirect pathway. Okay? Dopamine activates direct pathway, inhibits indirect pathway. The result is excitation. When it's lost, the direct pathways become strong. Okay? So the result will be some hyperactive condition and some hyperactive condition. So at the same time, the patient may show hyperactivity in some pathways, hyperactivity in some other pathways. So let's see what happens. We will have rigidity, which is a manifestation of hyperactivity, some involuntary tremor. Okay, we had also tremor for the cerebellum disease. But tremor for cerebellum happens when the patient wants to do a movement. So we call this intention tremor or action tremor. But here tremor happens when the person is resting. So in the resting state there is tremor. We call this tremor at rest. Okay? So tremor at rest or involuntary tremor is an indication of Parkinson's disease. Difficulty initiating movement, we call this akinesia or akinesia. Okay? Akinesia is problem with initiation of the movement. So the person wants to do this movement. Okay? The initiation is very slow. The patient tries to do this, it's very difficult, and after some seconds, it stops the movement. So we call this akinesia. So movement happens slower with some delay. Okay? Postural instability leading to poor balance and falls, dysphagia, speech disorder, gait disorder, fatigue. All of this happens when there is Parkinson's disease. Treatment is with L-dopamine. So there is problem with dopamine release, I told you, okay? Neurons that release dopamine in the substantia nigra are lost. So the result is Parkinson's disease. In order to treat the person, you should give the dopamine. Dopamine itself actually cannot penetrate the brain, I mean the BBB, and it's degraded by the enzyme very fast. So it's not a suitable drug for treatment of this patient. Okay? So the best drug is L-Dopa, which is a precursor of the dopamine. It's converted to dopamine inside the brain by some enzymes. Okay? So you give dopamine, L-Dopa goes into the brain, inside the brain, is converted into dopamine, then dopamine increase dopamine level in the brain, so you will have some level of recovery or improvement. Okay? Another drug is L-deprinil, which inhibits MAO, MAO, monoamine oxidase. I told you that all monoamines are degraded by monoamine oxidase into the actually substances that were used for the substance. For example, we have norepinephrine, dopamine, serotonin, histamine. So all of these are catecholamines. So they have amines, right? All of these are degraded by monoamine oxidase. So in this patient, you have loss of dopamine. In order to increase the level of dopamine, you can inhibit this enzyme. Okay? So L-deprinil inhibit enzyme. So all of these are increased in the brain. One of them is
Dopamine.
Dopamine can compensate for the loss of the dopamine in the brain. Okay? There are also some other treatments like transplanting fetal dopamine cells, destroying some part of the basal ganglia. So, basal ganglia is a network, right? I told you that, for example, we have some succession of neurons. All of them can be excitatory or inhibitory. So when there is a problem in this whole circuit, you can remove one of these. Then the action of the whole circuit is changed. For example, in patients with Parkinson's disease, usually globus pallidus is removed. Sometimes substantia nigra, subthalamic nucleus is removed by the surgery, I mean. Okay, the whole circuit is changed, so the result is some improvement in the activity of the test. Okay, another treatment which is very new is EES, deep brain stimulation. The surgeon puts some electrodes into the globus pallidus. The electrode is connected to some signal generators located beneath the skin, below the skin. So the signal generator always generates electrical impulses that is sent to the brain by way of the electrode. So the globus pallidus internal is always activated. Okay? So instead of being activated by way of the dopamine, it's activated by electrons. So this way the whole signal is improved. Okay? Tremor is lost, so there is improvement. Akinesia is lost, so when the person wants to do this, to do any movement, they can perform the movement very fast. Okay, so there is no lag, there is no stopping the movement. There is no bradykinesia. Bradykinesia means small movements. So when you walk, you go like this. Okay, a person with Parkinson's disease go like this, small gaits. Okay, so the start of the movement and the stop is very small. Okay, so the movements are small. Okay, so this is the case of Parkinson's disease. So we call this bradykinesia. Bradykinesia can be also improved by EES, these treatments. Okay, so let's see some. So Huntington's disease is another one. Okay, so you read it by yourself. Let's see some videos. You can find all of these videos in the YouTube. Okay, for example, let me show you the chorea. So it's like this. So actually the face of the people are shown here. It's not ethical, okay?
Yeah,
Could you please turn it off? This one.
This one.
Yeah.